Good afternoon and welcome to Sendero Health Plans webinar, Equity Gaps in COVID-19 Vaccine Uptake, a community conversation. Please welcome Rudy Ibarra from Sendero Health Plans, who will moderate this event.
Thank you, and good afternoon. Before we get started, I'd like to briefly go over the format for this webinar. There will be two parts, a 20-minute presentation followed by a 40-minute panel discussion. There are many participants on today's call, and as such, we ask that you keep your computer or phone on mute during the presentation. We will have opportunities to obtain your input today, and we look forward to this feedback during the questions and answer session. Simply type your question into the chat box located beside the slides. In the interest of time, we will address as many questions as time allows. Any questions we do not address during the webinar will be documented, and responses will be sent out to all attendees. We welcome participation from media on today's call, but we kindly ask that you keep your questions to the end, at which time we will conduct a media Q&A. This meeting is being recorded, and Sendero will make this presentation available to you after the meeting in English and Spanish. For today's agenda, we will have opening remarks provided by Tiara Thomas, Chief Operating Officer for Sendero Health Plans. Data presentation will be provided by John Leidiger, PhD, and Richard Taylor, PhD, followed by a panel discussion with questions for participants. Our panelists today are the Honorable Margaret Gomez, Travis County Commissioner, Precinct 4, Ms. Cynthia Valadez, LULAC and Central Health Board of Managers, Ms. Stephanie Hayden Howard, Director, Boston Public Health, Dr. Mary Carol Jennings, Chief Medical Officer, Sendero Health Plans. Closing remarks will be provided by Wesley Durkowski, Chief Executive Officer, Sendero Health Plans. And the next steps will be discussed by John Leidiger, PhD. At this time, I will turn it over to Tiara Thomas, Chief Operating Officer for Sendero Health Plans. Tiara?
Good afternoon. Thank you for joining us today to discuss the findings from a survey that was provided to Sendero members regarding their acceptance of the COVID-19 vaccine. Our community and high-risk members are very important. Therefore, this discussion is just as important. We need this discussion to help educate those who need the information and those who are planning our next steps. This community conversation is underway, and we appreciate you taking the time out of your day to have this discussion with us. Dr. Leidiger?
Thank you, Tiara, and thank you, Rudy. And I have to say, I realized I was the one that did these slides, and I realized that I've put Miss Stephanie's husband's name first. I thought it was about time that he got a little bit first dibs on the Hayden Howard hyphen. So, but as we all know, it is Miss Stephanie Hayden Howard. So I apologize in advance for that, Stephanie. So a couple things for today. Before we get started, I just want to make a couple of acknowledgments of how we got to where we are today. We started working on this idea back in September of 2020, looking at social determinants of health related to COVID-19. And as we started to put this together, we wanted to ask some specific questions about COVID-19, the vaccine itself. And so a lot of people have been involved with this. Myself, Dr. Richard Taylor, who's with us, and Richard is here, to add clarifying remarks and to help answer questions if there are any. But we also have a lot of folks who've helped us with this along the way. Our research associates, Naomi Thomas and Carlos Lopez Bray, have been helping us. Staff at Sendero, Allegra Hastings Martinez, Rudy and his group, Tiara and her folks. And so a lot of people have contributed to a lot to help us get here today. So I just wanted to acknowledge folks, because even though we're presenting today, it really is an effort by more than one person to make this happen. So we do appreciate that, and also our friend Bill Noble, who helped us quite a bit with the survey platform. So thank you all. So for today, I want to talk about two things. One is I want to give an update on our January 2021 publication and revise our estimates of the 1.7 million doses that we previously talked about needing to reach herd immunity. And this is because we now have the one dose Johnson & Johnson vaccine. So we want to talk about some updated numbers and how this one-dose vaccine we think impacts this. And then the main thing we want to talk about is data on equity gaps and discuss our findings from a cross-sectional survey of Sendero members that we conducted between November 11th and December 22nd last year, towards the end of the year, and really looking at their plan to take the COVID-19 vaccine when available. And we looked at it particularly around some demographic factors, the sex of the person, race, ethnicity, household income, educational attainment, and then also by age, although not quite as young as the little child on the graphic would indicate. We started at age 18 and above. And so this is what I kind of want to talk with us about. So I'm going to talk a little bit here about the number of doses we think still need to be administered in Travis County to reach herd immunity. Column A looks at our initial estimate in our paper in January in Frontiers in Public Health, where based on Travis County population, a herd immunity vaccine, induced herd immunity of 67% and the 2-dose vaccine, we estimated that 1.7 million doses would need to go in people's arms. Now that's not people, that's doses, because we had a 2-dose vaccine. But now we have the J&J 1-dose, and it's likely that we're going to have more 1-dose vaccines in the future. So we wanted to kind of think about what this looks like going forward. And so we've done 2 examples with this. Columns B and C look at a 1-dose penetration of 30% versus a 2-dose penetration of 70%. So meaning going forward, if 1-dose accounts for 30% of the vaccines administered, and the 2-dose accounts for 70% of the vaccine administered, what are we looking at in terms of vaccines still to be administered? And then we also did an estimate of a 50-50 split, so 50% 1-dose, 50% 2-dose. In columns B and C, we also looked at 2 different levels of herd immunity, 67% to be consistent with our original estimate, and then also at 80% to take into account some discussions about the new strains that are circulating and unknown efficacy with some of the vaccines, and looking and said, well, what would the herd immunity be if that was the case? And so we're looking at 80%. And what we see when we do a 1-dose split and a 2-dose split between 30% and 70%, we're seeing anywhere from 977,000 doses still to go in people's arms, or up to 1.25 million doses to go in people's arms. If we look at a 50-50 split between the 1-dose and the 2-dose, those numbers come down slightly to about 882,000 for 67% vaccine-induced herd immunity, to about 1.13 million doses. So we don't really know what this split is going to be, but we wanted to try to give an estimate so we can begin thinking about how much work is still ahead. A lot of good work has been done, and Stephanie and I were talking before the session about staff and the hard work that they're doing day after day to put shots in people's arms. So a lot has been done, but there's still a lot to do. And we're estimating that there's anywhere between 643,000 people and 809,000 people still to be vaccinated. Doses depend on the vaccine mix of 1-dose or 2-dose and the herd immunity. We've split this 2 number here and between column C and column D, and have said on average we believe there's about 1.07 million doses that still need to go in people's arms. And if we did a simple average of that at 25,000 doses a week, that would take us to December 31st. I know Stephanie had made some remarks to the Commissioner's Court yesterday about this, and we've talked about her numbers. And although the numbers may look slightly different, they actually do align very well, because we just did a straight average with ours. But I think mass vaccination clinics are still a critical part of this, as are the private providers. But the new circulating strains and any unknown vaccine efficacy against these strains is going to impact what we have. So the takeaway is we still have a lot to do. And I think the other important takeaway is, as we look into the data from the cross-sectional survey we did, we have to think about the 1 million some doses that we still have to put into people's arms is made up of distinct groups of people. And so we need to think about these groups of people. What types of issues are occurring with them with regard to vaccine hesitancy? Because in order to get to this 1.07 million doses, we need to make sure that everybody who wants to get vaccinated can be vaccinated. When we talk about our cross-sectional survey, I just wanted to give you a sense before I go into the data about what we did, why we did it, what we haven't done, and what we still have to do. And typically when one conducts research, there's 4 phases that you look at: an exploratory and a descriptive phase, a correlational phase where you're trying to look at relationships, and an explanatory where you're looking at cause and effect. We're going to talk about the first 3 today. Our focus is to understand the data, to describe the data, and to look for correlations among the data. So we set out with some hypotheses. We investigated this. We have a detailed picture of some of these variables that we've looked at, and we started looking at relations and some factors of influence. That's what we're going to talk about today. The explanatory piece, we still got work to do, but that's neither here nor there for today. A couple of descriptive findings that I'd like to look at first. This question here, or this statement here, respondents plan to take the COVID-19 vaccine, is the essence of what we were trying to get at for this particular piece of work out of this cross-sectional survey. Do you plan to take the COVID-19 vaccine? We had 1,648 people respond to the survey. Almost 2/3 of them said yes, they do plan to take the vaccine. A little over 5.5% said no, a little under 4% said not sure, and then over a quarter said prefer not to say. This is an interesting box that we don't see show up when we ask this same question about the flu. It's almost non-existent, but for some reason it's here for COVID-19 vaccine, and we have some ideas about this, but this is where we stand just from a descriptive piece. We've also stratified this by African American race and Hispanic ethnicity, and I've done this for the next slide as well, because I just wanted to see, since we're talking about equity, looking at these 2 variables and these 2 factors, where do these 2 groups lie? And we can see that within the African American population, 34.9% said yes, they were willing to take it, which is quite, or plan to get the vaccine, which is quite a bit below the overall yes. And you can see that the prefer not to say is quite a bit higher than the prefer not to say, as is for the Hispanic community as well. And also the no's votes as well here, the no responses was quite a bit higher for the African American population. As we look at the next set of slides, we're going to describe what we call bivariate analyses, and that's just the fancy book learning word for 2 variables. So bivariate, so 2 variables. And we're going to look at one variable against another, with the main variable, the primary or dependent variable that we're looking at is, do you plan to take the COVID-19 vaccine? But before we do that, I'll talk about age. I got ahead of myself. We also wanted just to give you a sense of descriptive findings for age. We've bucketed age into 3 groups: the 18 to 34, the 35 to 49, and the 50 plus. Most of our membership drops off at 65 because we don't have Medicare plans, but we do have 100 or so, several hundred maybe, who are 65 plus, but most of our membership drops off at 65. So this just gives you a sense of the age distribution. When we break this down by African American race or Hispanic ethnicity, we see that it's very similar to what we're seeing here, but the mean age, or the average age of the respondents, was 46.8 years old. Now, looking at our bivariate analyses, the next set of slides do a couple things. On the left-hand side in the table where we have data analysis, results, and interpretation, this is meaty stuff that we thought some people on the call may be interested in. And so as you're looking at the data, you may want to know specific information about the dependent variable, which is the main variable that we're assessing, the independent variable, the test that we used. The thing of interest from this left-hand side that I'm going to discuss is what's in red, which is an analysis finding that we had. But what I really want to focus on for this slide and the next 4 slides is the right-hand slide. And this is the slide that answers the question, did you say yes to plan to take the COVID-19 vaccine? So in this particular instance, we see that 58% of the females who answered this survey said, yes, I plan to take the vaccine. But we see here that 71% of males said that they plan to take the vaccine. So we have a gap here. And the gap is the difference between these 2 proportions is 13.7%. When we measure this gap and look at this gap statistically, what we're able to say is that persons who are female sex were 19% less likely to say yes. And that is a statistically significant finding which says to us from a research perspective that this is a finding that we would not have expected to occur by chance. So we think it's a real finding, we just don't know why. So there's a nice size gap here between females who said yes and males who said yes. One other thing I'll call your attention to is the scale from starting from 0% at the bottom to 80% at the top. The next slides use the same scale because I wanted you to be able to really see the gaps that we talk about, but not have them be influenced by different scales. So when we look at Black or African American race, 34.9% of African Americans who answered this survey or who identified as African Americans said yes, they plan to take the vaccine. Non-Black or African Americans who identified as such, 65.6% said they plan to take it. And you can see here, this is quite a big gap between, almost 35% and 65%. Big gap between those who are African American say yes and those who are not African American who say yes. And when we analyze this, what we're able to determine is that as a race, African Americans were 47% less likely to say yes. Again, that is a statistically significant finding, something that we would not expect to occur by chance alone. So something's going on there, we just don't know what it is. In this particular, this is the only slide where I actually comment on numbers in this box. We had 83 persons who identified as Black or African American answer this question. You may think, well, that's kind of a low number, and I don't really have a comment on whether it's low or not, but what I will say, it is more than sufficient for this statistical test for us to be able to come up with these results. So we feel very confident about these results, and it's statistically significant to a very low level. When we look at ethnicity by Mexican, Mexican American, or Chicano, we see a gap as well, not quite as large of a gap as for African Americans, but persons who identify as Mexican, Mexican American, or Chicano said yes, they plan to take the vaccine at 55% of the time. Those who were not of that ethnicity said they plan to take the vaccine at 65% of the time. So again, a gap of about 9.6 percentage points. So this leads us to say that Mexican or Mexican American or Chicano ethnicities are 15% likely to say yes, that they're going to take the vaccine. Again, that's statistically significant. It's a real finding among our population. We know it's there, but we need to figure out why. If we look at educational attainment, you also see a gap, a little bit bigger than the ethnicity gap, but certainly not nearly as big as the Black race gap, where those with a high school diploma or less, about 55% are saying yes, they plan to take the vaccine, as compared to those with a bachelor's degree or higher, which is 68.7%. So there's a gap between these two. And so what we can say is that individuals who have up to and including a high school diploma were 21% less likely to say yes than those with a bachelor's degree or higher. And then our final one, before we get into the age, is looking at by household income. Again, you can see a gap here. Those who earn $30,000 a year or less, 60.4% said yes, they plan to take the vaccine, as compared to those who make $30,000 a year or more, who said 68.1% of them said yes. So again, there's a gap, and when we analyze and measure that gap, we can say that those who have an income of less than 30% were 11% less likely to say yes to getting the vaccine. And again, that's statistically significant. So what this is telling us is that there are some findings with these particular variables that are gonna impact a person's vaccine hesitancy. When we look at age, we've done a couple things here because we think age is an important factor overall. And if you look on the left-hand side of this column, where we start with female sex, go down to Black sex, Mexican ethnicity, high school diploma or less, or households making less than 30,000, this is the information that I presented to you on the last slides. And you may remember this one in particular, because to me, it just jumps out that if you're a Black race, you're 47% less likely to say yes to getting the vaccine than if you're not a Black race. What we wanted to do with this then is look and see across these age categories, what does it look like if you're young, middle age, or as I like to call the wisdom years, since I just turned 50 last year, what does it look like in these different age categories? In the cells where there's nothing in the category, we're not seeing anything that is statistically significant. So there's nothing in these age ranges that would indicate to us that there's some difference specific to that age range. But we do see some differences in, for example, in female sex in the 35 to 49 and 50-year-old. If you're a female and you're in the 35 to 49-year-old group, you're 16% less likely than males to say yes to get the vaccine. If you're female in the 50-year group, you're 24% less likely to say yes that you'll get the vaccine. I'm going to come back to talk about the little asterisks here for these two in a minute, but you can see a similar pattern across Black race, that in all three age categories, you're less likely to get the vaccine than if you're not of Black race. And so see a similar finding within the 35 to 49 year group for Mexican American, or Chicano ethnicity. Within the high school diploma or less, we see a pattern here in the 35 to 49 and in the 50-year-old. And those households that make less than $30,000 a year, we're really seeing that finding pronounced within the 35 to 49. These two notations, the asterisks here and the asterisks here, indicate that while we do have a p-value that's less than 0.05, the confidence intervals also cross 1. So it's kind of a statistical anomaly, for lack of a better word. So in some ways, we're not willing to commit ourselves to saying that this is statistically significant because of the confidence intervals. But we left it in here because we do see that there's something going on here. And from a practical perspective, if we're thinking about outreach and education, there's still something going on here in this group and in this group where we probably need to look at. So then, kind of to tie all of this up, it's why does this matter? And I think, as we've been talking about this internally and as we've been working on the manuscript, I think our thoughts are kind of as follows. So one, exiting this crisis is going to require population level herd immunity. If we don't have that, we're not going to leave this crisis. Achieving that population level herd immunity requires vaccination, pure and simple. We must make sure that everyone has information, that they have education, and they have access to the vaccine. And that it goes across all age groups. It also occurs by different demographic variables. The other point I want to make is that we are most certainly not all in this together. That was kind of the statement at the beginning of the pandemic. I think it was a feel-good statement. But what we're seeing is, by and large, that those who are at the economic margin of society are the ones who have been crushed by this pandemic, and they're going to continue to be crushed until we exit this crisis. So as we think about what we need to do as a community, we have to realize that there are people who are hurting in this community. They've lost their jobs, they can't pay their mortgage, they can't pay their bills, they can't buy their kids the things that they need. And as we try to exit this, we need to make sure that we're doing everything we can so everybody comes out of this crisis, if not stronger, at least on the way. And then finally, it's about the social fabric of society, and that each day that we're not putting a shot in someone's arm is one more day that we are pulling our social fabric apart, one thread at a time. I thank you all very much. And Richard, if you have any comments, I'll ask you to make them. And if not, we'll turn it over to Rudy.
Thank you, John. I concur with your findings. I was really more here in case you had a question or something related to the statistics, but I appreciate being here.
Rudy, we'll turn it over to you, sir, and I'll see if I can figure out how to work this PowerPoint again. There we go.
Thank you, Dr. Latiger. I appreciate your presentation very much. At this time, we want to turn it over to our panelists to discuss your findings and get their thoughts on their findings. I'm not sure if Commissioner Gomez was able to join us after all. I don't see her on here, but again, our panelists for today are Cynthia Valadez with LULAC and Central Health Board of Managers, Stephanie Hayden Howard, Director, Austin Public Health, Dr. Mary Carol Jennings, for Chief Medical Officer for Sendero Health Plans. So if you have any questions, just a quick reminder that you can enter your questions into the chat box located beside the slides. We will get those questions and field them as they come in. Any questions that are sent, we will document. If we are unable to get them get to them today, we will certainly keep record of those and send responses to all attendees for today. So with that, I will turn it over. Ms. Valadez, did you have any thoughts about the findings that you wanted to share?
I'm sorry, can you hear me?
Yes, we can hear you. I can hear you.
Okay, so what we know so far is that we must achieve herd immunity. At least 70% of our population must become vaccinated, targeting historically underserved and marginalized communities living in zip codes with the lowest 25% census measures taken into account are known determinants of life, as I call them. And we have to do that as quickly as possible. What we don't have is data that shows exactly how many doses have been injected, how much of the vaccine has actually gone to residents living in the highest poverty neighborhoods with the highest incidence of COVID and deaths. Compare this information to the wealthiest parts of Travis County, and most importantly, that it be appropriate to the demographic data representative of our existing population that also includes language barriers, immigration status, and self-identifying gender status. Do you want me to go on? Hello?
Rudy may be on mute. If you do, and Ms. Valdez, this is John. If there's anything that came out and struck you particularly about these findings, that would be helpful as well. But then we'll also ask Ms. Hayden Howard and Dr. Jennings for their thoughts as well. But if you have other comments and would like to spend another minute or two, please do.
Well, I do have other comments, but what I did is write them down based on the various questions that we were going to be asked, assuming that we were going to do them one by one, and each person responding to that particular question. Unless, if you want me to go on, I will, but because I have answered all the initial questions. Dr. Littiger, what would you like for me to do?
I would suggest let's give the other panelists a chance just to react to what they've seen and thoughts that they have from their vantage point of their different jobs. So maybe if we can go to Ms. Stephanie.
I would just like the opportunity to come back and finish my comments. Thank you.
Thank you for the opportunity to be here today. Some of the findings are surprising to me. We always knew that there would be some level of vaccine hesitancy, but what surprised me is that more females were saying no. And one of the things that we have done is that we have entered into about 8 contracts with some of our providers that are going to continue those conversations with folks, because it's important to continue those conversations and to understand why people are hesitant to receive the vaccine. From events that I have attended, Dr. Pickett and I went to, for example, a Bible study, and it was a virtual Bible study. And we were able to provide information to the congregants and answer any questions that they had. Well, one of the really good things is that we had several of the folks that said, they were not sure if they were going to get the vaccine. At the end of it, they had changed their minds. And so we know that if we're able to have folks that are a trusted source and they're able to have those conversations, we can definitely improve the hesitancy. So I appreciate the data, because this is very good for us to have.
Thank you, Director Hayden Howard. Dr. Jennings?
Sure, thanks. So I just wanted to echo the call from Commissioner Valdez for geographic and income-based analysis of vaccine coverage, and to applaud the community-based efforts that Director Hayden Howard has shared, which are so critical. I just wanted to note, national and state eligibility criteria for the vaccine that you've all, made sure if you check off against if you've been trying to get the vaccine. They do address age, but they're silent on race and ethnicity, likely appropriately so. However, African American and Hispanic members of our community are the hardest hit. We've all noted that since the beginning of the pandemic. We see the largest COVID-19 disease burden amongst people who meet those demographic characteristics. Yet, as health departments are seeing across the country, vaccine uptake here in Travis is lower among people who are in these demographics. And to counteract the disproportionate burden, I think these data really emphasize that we need to implement, disproportionate proactive efforts to improve access to and uptake of COVID vaccines, which are, really at the end of the day, really powerful tools of prevention. Now, I myself come from a vaccine program and implementation science background, and vaccine hesitancy is a confusing term to everybody. Really, when you break that down, somebody might have questions today, but not actually describe themselves as hesitant. They're just not ready, or they're going to change their answer to yes after some questions are answered. For example, the community conversation Director Hayden had shared. And although in these specific survey results, 64% of our respondents did indicate they would take the vaccine, I think that's an important positive finding to emphasize. Our data that Dr. Leidiger had reviewed show a particular tendency for kind of a reluctance to commit to taking the vaccine amongst African Americans, where only 1 in 3 said yes, that they were going to commit to the vaccine. And, a present but smaller difference among Hispanic members compared to non-Hispanic members, and also, a signal around middle-aged members, but let's focus on the race ethnicity for my comments. Just to come to a conclusion here, in as much as the Sendero membership represents those that our community has offered perhaps the least opportunity to, I hope that these data can be used to inform how we collectively offer the opportunity to vaccinate, to support continued increased outreach and social mobilization efforts to members of our community in these particular demographic groups who told us they had less intent to vaccinate, so that they can feel more confident in our public health approach in our medical community and in the promise that the COVID vaccines hold for our community. Thanks for the opportunity to respond. Back over to the moderators.
Thank you, Dr. Jennings, and thank you, panelists. Dr. Leidiger, did you want to offer some commentary on the comments from the other panelists?
I'll note a couple things, Rudy, just some additional data points that we for lack of time we didn't have, but I'll just note a couple things here with the population that we're looking at, and I appreciate Dr. Jennings' comment about the Sendero membership and the people we serve. Tends to concentrate, I think, on a more marginalized population economically to some degree, although that's not always the case. But when we look at our respondent education level, we can see, that quite a few or the majority of our respondents, have a 4-year college education or higher, and that's a little bit lower across the African American, Hispanic demographics, but they're consistent within those two. And then the other thing, just to point out, is that the household income of the respondents. And I think one of the things that struck us when we were looking at this is that about 42% of the respondents earn less than $30,000 a year. And so, to me, what that says is that if we're trying to use this data to help us make decisions about economically marginalized populations, that our data that would allow us to do that just because of some of these demographics. That's all for me, Rudy. Sorry.
Okay, no, thank you. We appreciate the response and the findings again. And I just want to make a very quick reminder to the attendees that if you have any questions, please type them in the chat box, and we will take them as they come in. For the panelists, and there are a few questions I'd like to ask here. What about natural immunity? Is that considered in this 1.7 million, or how does that factor into that at all? Perhaps Dr. Leidiger or Dr. Jennings would like to talk about that.
I'd be happy to take the first response briefly. So we know that natural immunity after infection with COVID, with the actual virus, lasts for a handful of months in most people, but we don't have any data beyond that. And we don't know how long it will protect an individual, and we know it is a lot less standardized than the immune response that we get after vaccination. Anyone who's been infected with COVID, CDC and local and state health departments still very much recommend that those people receive vaccination. So it wouldn't be appropriate to, because there are so many unanswered questions on how long natural immunity might last, and there's such a degree of variation amongst the population, it wouldn't be appropriate to base herd immunity standards on so many kind of unanswered questions. Dr. Hayden might have other responses, or Dr. Leidiger as well, but that would be some important notes to take into account.
Director Hayden or Dr. Leidiger, would you like to offer up?
I'll defer to Ms. Stephanie if she has any comments, and then I can make a quick comment.
I think one of the main things that, because this is such a new, COVID is such a new virus to us, and really thinking about from a best practice perspective, I think it's going to be so important for us to be able to get the vaccines in arms, as soon as possible. What we have started to see is that there were some folks that had the virus last year, and then they have been reinfected. And we've seen it in different ways. Maybe the first time they were infected with the virus, it was a mild case, not any symptoms that they could pinpoint. And then the second time around, it was more severe. And so we really want to really address and provide vaccines, whether it's Austin Public Health or one of the approved partners. We really want to move to herd immunity by providing that vaccine to as many people as we can.
And this is John. I think when we looked and did our estimates originally in January, but with our updated estimates for today, I think that we presented here today, I think one of the things that we were really trying to do is say, look, we took the population from the census and looked at 67%, including children. There'd been no data about any immunoglobulin data that I'm aware of locally that we could have used to say this. But I agree with Stephanie, Director Hayden, and with Dr. Jennings that to exit this crisis, we need to get people vaccines in people's arms. So our calculations are just from a straight population perspective, realizing that there's going to be people who have natural immunity, but if we can achieve this type of herd immunity from vaccines, that's any natural immunity above that's only a plus, in my opinion.
Excellent. Thank you for your comments on that. We do have a few questions coming in from the attendees I'd like to get to. First question here is, with the statewide mask mandate ending today, do you have any data on the likelihood someone will wear a mask? Dr. Leidiger, would you like to start, and perhaps we can go to Director Hayden after that?
What I can show you, and I put a slide up here. So one of the questions that we asked folks is, or the statement is, your belief that wearing a mask can protect against COVID-19. I mean, you can see here on the left-hand side, 88.89% of the people said yes, even with the breakdown between race and ethnic groups for African American and Hispanics, we saw the same thing. So among our respondents, there's no question at all that they think wearing a mask is a good thing. I make no comment about the change in the directive, but this is what our folks have said.
You know, what we know about I'm going to call it the fight against COVID to keep everyone protected is that these non-pharmaceutical measures do work. There have been studies that show this has helped us all as we continue to wear masks and to wash our hands and to watch our distance and to stay home if we're not feeling well, and go and get tested to know your status if you do have COVID. And so, you know, we are continuing as a city of Austin with our local health authorities to continue to keep that requirement in place through the health authority orders. And so we are going to extend that, you know, for businesses throughout through July. And so we feel like by having that additional measure in place, it does give folks a little bit more security, because we know that these have been proven measures. The other thing is that it gives us more time as a community, all of the providers, to provide the vaccines to people that want them, and to address any hesitancy. And so, so we feel like that time frame that takes us through the month of July would really help in Travis County.
Thank you. I just want to do a quick time check here. We've had about 16 minutes to the hour. A couple more questions have come in. I want to take a minute to see if Ms. Valadez, did you have any statements that you wanted to make with regard to this statewide mask mandate?
Yes, please. Well, not only to the mask mandate, but to the need to provide information, education, and vaccines to our historically excluded and marginalized populations. And that would be in the form of additional buy-in by our elected and appointed officials. It would require the implementation of strategies that are culturally and linguistically appropriate. It would mean partnering with community-based organizations that have a historical roots in our individual and distinct communities. And it would mean the building of trust being the most important thing to be achieved by this. That should be a primary goal. However, we need that buy-in. We need funding. We need to put in place strategies that have historically proven to be successful in the past, such as providing resources to our distinct communities and making sure the resources are there to address this pandemic and remain there in place long-term, so that these neighborhoods and these communities can basically take responsibility for monitoring their own and for making sure that they climb out of the economic hardships that have been produced as a result of this pandemic, which all it did was highlight the disparate gaps and the huge disparities that existed in our historically marginalized populations through generations and generations of structural racism. So I think that with a buy-in by the elected and appointed officials, with the commitment that they personally will make sure that their offices commit to focusing on long-term achievement of the goals of eliminating this crisis through continuing to wear masks, through maintaining safe distances from each other, practicing good hygiene, and being responsible not only for themselves and their families, but for their communities. We've got to provide that opportunity. This is a unique opportunity for us to be able to create those partnerships with individual members who have historically been excluded from the decision-making tables, and we're not there for develop a plan that really didn't appear to exist by the public health entity and by the task forces, which were put in place to address the vaccination needs. We need to overcome that hesitancy, and it will be overcome, but it will be overcome only with the partnerships of those trusted voices in their communities who will take responsibility, be funded to provide input, to provide, like Stephanie said, the information, the education, to be able to overcome the hesitancy to take the vaccine, and for them to reach out into their individual communities that are being excluded due to digital divide issues, the fact that they don't have an email address, the fact that they don't speak the language, all that is necessary. All those things are necessary to overcoming what this pandemic has shown us to be a most important issue, and that was that the haves continue to have and the have-nots don't get. And that won't happen unless we ourselves are involved to the greatest extent and appropriately according to our representative demographic. Thank you.
Thank you, Ms. Valadez. I think those, yeah, certainly, Dr. Leidinger, go ahead.
Sorry, Rudy, I didn't mean to interrupt, because I take Cynthia's comments really seriously, that there's still, gaps and divides. And I think, some of the things that we've seen, particularly, if we look back at this slide here, we see some of these. My question would be to folks who are listening in, how do you see us as a community coming together and addressing some of these? Because certainly funding is an important issue. I mean, you need funding to do things, but even if you got the funding to do it, there's still things that have to be done. I mean, money is just not going to solve the problem. So I think it'd be helpful for us to capture in the chat box, what ideas do you have? There's a lot of people on this call who know our community really well. What would you do if you had that money? What types of things would you do to try to address this vaccine hesitancy across Black race, which is apparent across all age groups, and within the 35 to 49 year age group? What would you do? We would really appreciate your comments on that, so we could record that, because I think we really want to take away from this meeting some ideas and some things that we can look at going forward, not just having the data, but being able to do something about the data. Thank you, Rudy.
John, just to get that conversation started while people are chatting in responses to you, just wanted to share in response to Commissioner Valdez's comments, something that Sendero's been doing. So our community health workers and our member relations teams have been leveraging that personal connection that they have, especially with our highest risk members, and have been conducting outreach and scheduling appointments for those who want to get the vaccines. And I know that efforts like this, representatives from many other community partner organizations could share similar stories, but I've just been so glad to see that role that our staff members, our team, can play in supporting our own membership, and wonder what others are doing and what else others might like to see the community doing, as Dr. Leidinger suggests.
Thank you, Dr. Jennings. We do have some more questions that I'd like to get to that are on the chat. Are there any specific strategies to work around the technology gaps, since every vaccination registration sites appear to be online only? Director Howard, would you like to take a stab at that?
Yes. One of the things that that the city set up is we have an equity line that we have established, and they are providing outbound calls to individuals. We have some nonprofit partners that are, that have always worked with, different folks that they normally work with or have increased and provided services to now during this time. And so they are referring to our equity line. And so the people that we are reaching out to, we are setting up an account. We are scheduling them for the vaccine. We've been alerted that there are some folks that are homebound. And so our mobile team has added them to the list. And so we have been out to the housing authority, have partnered with them to provide vaccines to seniors and people that are disabled initially. And so they did not have to have access to to technology, but what our staff did is we worked with the housing authority, for example, for them to get the list, provide the location, maybe it's a community room, etc. And then we just brought them in one at a time. And so you really must always consider that that you must have an alternative to technology. I know technology is great; it works, very well, but we got to always acknowledge that there is a divide, and there are folks that don't have access to the internet, and then there are folks that may have created an email account, but they don't have the ability to sit and be online to register. And so we'll continue that process. One of the things that we've also done is working with 311. And so folks could call 311 and leave a message for our equity line and say, I would like to get an appointment with public health. And so they will send that over to our equity folks and they will give them a call. I do understand that with the CODA platform as well, Travis County has some folks that are calling people that don't have access to the internet as well. And so you must always build that into your strategy.
Thank you. Another quick time check here. We are 7 minutes to the hour, so I will move on to the other questions. Dr. Leidiger, I think these questions are addressed to you. What is the sampling strategy? What was the sampling methodology? And why only 83 Blacks?
I'm going to ask Dr. Taylor to help with the first two questions. I think the answer, the straightforward answer to the third question of, why did we only have 83 African American respondents? That's just because how many responded, and we incentivized people with a gift card, a $25 gift card for HEB to respond, but to kind of understand why people didn't respond, we almost have to talk with the non-respondents. So it's like, well, if they didn't respond, they're probably not going to want to talk to us about it. So I don't really know of another answer to say that's what we got. I will go back to my earlier comment that 83 doesn't seem like a large number on the scheme of things, but it's enough to help us with these statistical analyses. So I feel like the model holds up with the analyses, even with that number. But Richard, I'll turn it over to you for thoughts on that and the other two questions.
Sure. Well, I think it's a great question. What we had set out to do was to send the questionnaire to all head of household members, and we had a definition for that. These were people who were responsible for the primary person on the Sendero membership, people signing up their families or themselves in the household. And so we sent the survey to all head of household members with that in mind. And we did get, I say, close to 20% response rate. And so we were reluctant to generalize this back to Travis County. We know the limitations of the data. What we are or were excited about was that we did get representation from all of the demographic groups that we talked about today. And so while they might not represent all of Travis County, we did see some good responses from people who are willing to engage with their health insurance provider and provide this information to us. And so, there's always limitations in data, and we accept the limitations of the data, and we accept the limitations of our ability to generalize across the data, not only just to Sendero, but also to Travis County.
Thank you, Dr. Taylor and Dr. Leidiger. Really appreciate that. I want to let the attendees know that we have 3 minutes to the hour. We have received numerous questions. As I mentioned, we will provide responses to those questions to all attendees. At this time, I'd like to turn it over to Dr. Leidiger and Wesley Dukowski to provide closing remarks. Dr. Leidiger?
I'm just going to give a couple just summary kind of takeaways from this. So I think, to me, some of the takeaways that we've heard is there's a divide. There's a divide economically, digitally, language, and there's factors that I think the data has shown where these divides actually influence whether somebody's going to be willing to take the vaccine or not. And so I think what we're seeing with the data is probably about what we would have expected to find, but what we're seeing with this is real data, real people living in Travis County, not having to extrapolate it from other parts. The pandemic has exposed these divisions. I think Mrs. Valdez was very eloquent in that divisions and how the pandemic has exposed these divisions. But a lot of work has already been done to put vaccines in people's arms, but I think we still have a long way to go. A lot of those is still to do. And public health is working. I mean, I just know from my other work with them how hard they're working to do this, and that assistance is needed to help identify and educate and begin to address some of this hesitancy. Funding is certainly a potential issue for that. But even if you get the funding, what are you going to do with the funding once you get it? So those are kind of the big highlights that I took away. And Wes, I'll turn it over to you. One quick thing though, we're still available to stay on the call. I don't know if all the panelists are, because I know everybody's very busy, but we're happy to stay on the call, for a little bit of time after the hour to answer any questions that people would like. Sorry, Wes, I apologize for taking so much time. We can't hear you, Wes.
No, thank you very much. No need to apologize. I appreciate all your work and your teams. I greatly appreciate the panelists and everybody listening. My takeaway and thoughts will try to be pretty brief. It's Sendero's 10th year as a community plan here in Austin, offering coverage to the community and fighting for care for the underserved. And in partnership with Sendero Health, we're proud that this year, and that includes over 1,000 of lowest income musicians in the community. We're offering them full coverage, and over 650 of the highest acuity, lowest income, formerly underserved in our community, who now have full coverage through a program with Sendero Health. This gives us an excellent window into the community, which we work closely with, reaching out, always 70–80% constant contact. And from them, the feedback is that we have a long way to go to meet the needs of these, especially among the underserved. Takeaways, yes, this study is critically important because it's a known defined population. It's Austin. Anything more than a few dozen statistically gives us more than enough to know, and since it lines up with what we've seen nationwide, we're comfortable that it is a very strong flag-waving call to action on both the infrastructure side, where you heard the discussions, and there's no time to be optimistic. Even at the lowest range of 650,000 doses, I mean, last weekend it was 15,000, so you say even if it was up to 25,000 a week, that means it would take until October to get the bare minimum to get some good out of close to herd immunity. So there's a lot of work on the infrastructure side. Can't thank Austin Public Health and everybody else who's working with them enough for working to put this in place, because it's a non-traditional distribution structure, and that's why we're partially flying blind. Can't see what's happening, can't see who needs it, other than that everybody can feel the pain of the underserved. So to end it back on Director Hayden Howard's and Manager Valadez's points, which is very interesting, how you mentioned that even just in a discussion with a church group, you were able to quickly identify this idea of hesitancy and instantly jump into the educational response needed. And so as Manager Valadez mentioned, what the community really needs, it sounds like, is an organized, broad educational outreach ASAP, just to overcome this hesitancy. So as the infrastructure gets into place, we can get everybody vaccinated, because to end on Dr. Leidiger's point, we are all in this together. You can't just have half the population vaccinated. That doesn't work. It's all of us, especially underserved, and that would give us the strongest community. So with that, I'll say thanks to everybody, appreciate it, And yes, we'll stay on. Happy to stay on for anybody who can stay on. Maybe answer some questions, have further discussions. Thanks.
So we'll close this then as the official, Rudy, if you'd like to ask more questions, please do. And I know Ms. Stephanie, if you're not able to stay on, certainly understand. Ms. Valdez, same, and Dr. Jennings, but if you are, that would be lovely. So Rudy, any other questions for the folks?
Yes, definitely. There's quite a few that have come through here. I'm going to ask them in the order they've come in. Next question here: since the population surveyed are insured, what do you think would be the influence of having no insurance on vaccine hesitancy and resistance?
That's a darn good question.
Dr. Leidiger, you want to take that?
You know, I would maybe if Dr. Jennings is still on and if Ms. Stephanie is still on. I mean, that's an excellent question, and I don't think I don't even know if I can even wrap my brain around it. Dr. Jennings and Ms. Stephanie, do you all have any thoughts?
It's hard to, thanks, Rudy. I'll take the question briefly. It's difficult to kind of make a statement about that. So I'll just speak kind of about, estimations and what I might expect to happen rather than like what is actually happening. A sizable proportion of our membership will be quite similar to people who live in the local community who are not insured. So there's, that to set to the side. But I think the other important point to make, and this message may not be getting out there, but I have seen it pretty prominently posted myself. But there's no fee to an individual person to receive a COVID vaccine. They're heavily subsidized by the federal government and are provided at no cost to everyone in the country. If someone has insurance, the insurance company is charged a small administrative fee from the provider administering. But I see Director Hayden Howard sending one, and she might want to follow up on that.
One of the things that most health departments do is that that's a core part of public health is to provide immunizations. And we typically provide immunizations to folks that are underinsured or that don't have any insurance. And so, ongoingly, we have continued to provide immunizations, to this population because it's important for us to make sure our existing clients still have a way to come through our adult shot clinics, even to receive this COVID vaccine. And so we are continuing to work through our existing clients as well, even though we've set up, the larger structures, the equity line, et cetera, we are still providing that. And I think it's really important that you continue your current infrastructure efforts aligned with the larger efforts of us being a hub. And what a hub essentially means is that we're able to provide vaccines, a large number of vaccines to the community in a short amount of time. And we also have to be able to provide them for anyone across the state of Texas. And so that portal is in place because we have to provide vaccines across the state of Texas. But why we've maintained our shots for tot clinics and adult shots is so we could continue to reach our uninsured or underinsured people.
Thank you for those responses. Looking at some of the questions here, Director Hayden Howard, this one looks like it's addressed to you. Pharmacies are going to play an increasing role in the delivery of COVID-19 vaccines. Have you established partnerships with local pharmacy partners to provide education to everyone who needs to be vaccinated?
We have a vaccine coalition task force that we meet, and it does include providers. And then outside of the larger coalition meeting, we meet with the providers outside of that meeting. One of the things that we've shared is that we've shared our guidance about kind of the best strategy to be able to provide vaccines, and making sure that, yes, we, kind of have the directive to make sure you're providing vaccines to people that are 65 years of age and older, but wanting them to make sure that they are also providing vaccines to people that if they have Medicare, if they have, they're uninsured, et cetera, that they are able to provide that. And so thank you for adding that. And so this particular strategy, looks at all of those things because, one, we wanted to secure the infrastructure, but then we wanted to prevent severe disease and death. And then we want to make sure that we are covering our essential workers. And so all of those things combined will get us to the point. And definitely the hardest hit populations, we've talked with them about, looking at the zip code and, providing vaccines to, folks that come to their sites that may live in one of these zip codes. And so we make all of that information public where folks can see the high positivity rate. And so that way they are able to align their efforts with our efforts.
Thank you. Looking at some of the other questions here. Dr. Leidiger, this one looks like it could be addressed to you. Is there any data as to whether respondents have been tested or would submit to testing for COVID?
I don't think we collected that. It seems like we had a discussion on that, but I'll ask Dr. Taylor or Naomi. Did we collect testing data? I mean, we can probably go back and look at it in terms of the claims for our members if a claim was submitted, assuming that it wasn't at a place where, one of the Austin Public Health clinics where I don't think they were necessarily doing that. But I don't think we asked that question. Did we, Richard or Naomi?
That's correct. We did not ask that specific question. However, we would be able to go back and look at the claims data that we receive over the next, usually a claim is filed within 90 days, I believe. And so we would be able to go back and look at that and match it to some of the responses we received.
Excellent. Manager Valadez, are you still on the call?
Yes, I am. I don't know if you can see me because I have been raising my hand, but that's okay.
No, sorry, I did not see that. My apologies. Did you have some thoughts that you wanted to offer up? And I also have a question I think that you could answer as well.
Start with the question, and then I'll finish it up.
I'd be interested in your thoughts. One of the questions that was asked here: what is the role of community health workers, folks that live in the communities most affected, that know the history, have earned community trust in addressing this response?
What is the role? The role is an essential one. We have to have community health workers aligned with the medical providers and the institutions that are they are the ones that live in the communities, they work in the communities, they know the population of those that in those neighborhoods that are most obviously the targeted populations for the lower socioeconomic census tracts. They live in there and they know the people. I have such a respect for community health workers. I started out working for as an advocate and a community health worker, and then working under Latino Healthcare Forum, who I merit with being having the best trained promotoras in the area. And we went to the legislature and to the federal government asking that that the feds create a billing code so that they could have become part of the structure a long time ago, years and years ago. That has yet to happen, but I believe that the medical professions are understanding the need for community health workers. We've gone to the state legislature asking that they pass legislation that has previously been introduced but not passed to ensure that in Texas, community health workers and promotores remained a part of the health industry, the healthcare industry, and the provision of services, because they are the liaison between the provider and the family, the member. And we need them because they're culturally and linguistically aligned to the communities that they serve, and they know the resources that are available and can provide that information to the families, and they can make sure that they connect with all their appointments, that they have the information in the background, get education that's necessary for them to be able to learn to advocate for themselves, because that's another role of a community health worker. They have to train and teach the families how to be their own advocates. They're just not there to connect somebody to services, although yes, they are there for that, but more importantly, to educate the family members. So that we can't do enough. I can't advocate enough for community health workers. And I'm very proud of our Sendero organization. It was created by Central Health, and Sendero has its mission of providing the best services that they can to our community. And so I just want to give Wes a shout out. But I also would like to say this and finish up by saying that within, in 2014, Central Health, which is the Travis County Healthcare District, was created by legislative action. We took over the responsibility for those that live and reside within the lowest 200% of the federal poverty guidelines. We did. We got the clinics. That's why community care exists under the auspices of Central Health of the Travis County Healthcare District. That's why Sendero was created, to provide comprehensive health insurance, which includes primary care, specialty care, mental and behavioral health services. And those exist when you have a comprehensive insurance plan. Under Central Health, we expanded the MAP program, which is a medical assistance program, and now the CHAT program, which is Central Health Assistance Program that Sendero has been managing, as he stated earlier, to the musicians and to the most medically needy in the MAP program. The issue is that in Travis County, we have over 175,000 people that are not insured. They're outside the system. They're not in MAP. They're not in CHAP. They're not in anything. They don't have access to comprehensive health insurance, which is what they need in order to stay healthy and what we need for our communities in order to improve their quality of life. You can't go to work. You can't go to school. You can't do anything if you're sick. And you can't become well again unless you have access to a medical home and to a doctor. And the only way you're going to have that for most people that live at that less than 200% FPL is if you have a clinic to go to or a charity care that will be provided to you. And that's not happening well. That is not happening well. So what we realized and saw with unfortunately, with the help of the pandemic, is that we have these gaps, these huge gaps in provision of services that our communities, and especially our non-English speaking communities, our poverty communities, our minority communities of color, of religion, of everything else, that are not being accessed, not being provided those opportunities. They're unable to overcome the barriers. And we at Central Health have been limited. And even with Sendero, we have been limited in providing them those tools necessary for them to improve their quality of life. So what we need and what I advocate for on a regular basis, every meeting, if at all possible, is that we expand the funding levels to direct healthcare services, to the delivery of healthcare services to our poverty population. If we could expand MAP, if we could expand Sendero's ability to, by giving them money, to be able to include more people access to comprehensive health insurance, then we would go a long way in eliminating a lot of the problems that we've got. But because we don't have what we used to have in our neighborhoods a long time ago, and those were community and economic development corporations within our distinct populations who could help our communities with our distinct communities with all the resources and the provision, knowledge, information, and access to resources you know, that would be a great equalizer. Those were done away with decades ago. And I think that it's time to return to something like that so that we can give, put overcoming the pandemic and overcoming disparate treatment to our minority and excluded communities, an equalized shot at actually achieving the same quality of life as is received west of 35. So I just wanted to throw that in, but that again is going to take a great investment of time, attention, and funding, and it's going to take that buy-in, as I said earlier, from elected officials and department heads and governmental entities that have been put in place to address the needs of our most vulnerable population. And that was the Travis County Healthcare District. Make sure that they have accountability on the people we fund, which includes Ascension Seton and the University of Texas Medical School, to make sure that we are getting our population covered. If they can't provide that accountability and that data, then we've got a problem we need to overcome. But we can't do it as a board unless we have the population involved in determining their own qualities of life. So I just want to thank you for giving me the time, and thank you for providing this opportunity to speak.
Thank you.
No, thank you. Thank you, Manager Valadez. Really appreciate your thoughts and your sentiments on that. Dr. Leidiger, we are about 19 minutes past the hour here. Did you have other comments in response to Manager Valadez?
No, I always appreciate Cynthia's comments. I really do. I always take them to heart. The only thing I was going to say is, maybe another question or two, and then we can wrap up. Just because I know, Stephanie, you've been very kind to stay on, Manager Valdez and Dr. Jennings, but I know you all have other things to do. But maybe another question or two, and then we'll wrap up. But then we'll make the commitment to try to get answers back out to those other questions that we don't get to.
Yeah, definitely. One question that sticks out here is, did you collect any information about willingness to get other vaccines or a flu shot? And if so, how do they compare?
We did do that. And let's see. So this was, and I'm going to give kudos to Dr. Taylor on this. Richard said we needed to add this. And so thank you, Rudy and Carlos and Naomi as well, too. You all probably had a hand in this. So we added this question here: respondent plan to get the influenza vaccine in 2021. And then we also asked if they got the vaccine in last year. What's striking, so this is 2021 now, which is we're having COVID vaccine now. You may remember me saying at the outset when we were talking about the COVID vaccine, the prefer not to say for COVID was about 26%. But here, what we see when we ask about flu vaccine, it drops down to 1.5%, and those findings are kind of redistributed between not sure and no. The yes stays about the same. There may be some violation of independence here in the sense that we don't know, if it's the same people making the same decision in both of those questions. But the results are striking. So there's something going on in the COVID question where 26% of people prefer not to say, but when it comes to flu, they're pretty happy to tell you they're going to lay it out on the line in one of these three responses. And Dr. Taylor, I'll ask you if you have other thoughts on this.
Well, another thing that's very interesting about this is that we actually have the ability to track whether or not there's a claim for influenza vaccine. So we can look, we were looking back. Originally, we had thought that these might help us predict whether or not people would get a COVID-19 vaccine. So we wanted to, get a history on that. And so we asked the question, did you get one in the 2019-20 flu year? And then we said, and this was in November, so we said, did you already get it, or are you planning to get the seasonal flu this year? And then we asked them, do you plan to get the COVID vaccine when it becomes available? And so we're currently analyzing the data right now, but again, we can look back at the claims for seasonal flu for the 2019-20 year and also the 2021 year as well, and see how that correlates with COVID vaccine uptake. And so we were really looking at this, and we were kind of concerned, especially in November, when some of the information, remember this was around the time of the election, et cetera, so there was a lot of confusion, but the country was also dealing with a lot of other things on their plate. And we were still getting the information about the emergency use authorizations and things like that for COVID. So we thought this might help us if we get the flu information. It might help us understand and get a jump on whether or not we need to start engaging with the community to get them to think about and plan for the COVID vaccine when it was available.
Thank you. Appreciate your responses,
Sure.
Dr. Taylor and Dr. Leitiger. There are a few comments on here that have come in with about possible solutions or other strategies, more mobile outreach, elimination of the paperwork that has to be done in advance, more drive-through locations in the underserved communities, more mobile outreach to seniors in their homes that are homebound and not on government programs like Meals on Wheels. So just a few of the suggestions that came through for solving some of these outreach or reaching out to the vulnerable or those with mobility issues. So I think the last question here is perhaps appropriate. Director Hayden Howard, this one was directed at you. Can you provide insight to the announcement from Austin Public Health that you could vaccinate 85% of Travis County in up to 12 weeks? And any background on that? I don't know if we're having audio issues or if Director Hayden Howard had to leave.
I'm sorry, what is the question?
Let me see here. The question is, can you provide insight to the announcement from Austin Public Health that you could vaccinate 85% of Travis County in up to 12 weeks?
Yes. So that basically what that does is through the Texas Department of Health, State Health Services, there are 350 sites that are approved to provide vaccine. And so if each of them were only to provide 267 vaccines over the course of 12 weeks, and we continued with our 12,000 and UT Health continued with theirs, that's how we would get to that level of vaccines in our community. And so the example that I shared is for example, for folks that have insurance or, Medicare, Medicaid, if you were a patient, for example, of Austin Regional Clinic, what they shared with us is that they are able to provide 30,000 vaccines a month in 30 locations. And what HEB shared with us is that they are able to provide 4,000 vaccines a day at 40 sites. And so really the bottom line is that once vaccines become more available as a community, all of the providers receiving adequate vaccines, we'd be able to, provide the vaccines. There are sites that are set up at the volunteer clinic, for example. They are ready to provide vaccines, but they would like to at least start to receive 500 vaccines a week so they can reach some of our marginalized populations. And so those are just examples of, when we were thinking about, how could we get to a strategy for herd immunity through vaccines, that is the way we would be able to do that.
Thank you, Director Hayden Howard. I appreciate your comments on that. Do any of the other panelists have commentary for that question?
Well, I'd like to add, currently, we do not have emergency use authorization for children. And so for us, you know, we can play the math game all we want, but until other things happen at levels of government beyond Travis County, you know, we're kind of stuck with not only the number of doses we receive from the state and also from the federal government, but also we're still relying on some of the science that is emerging. And one of those big pieces of information that we're waiting on is the ability to vaccinate our children. And so while we might have the infrastructure theoretically in place, I would say that you know, to add to what Stephanie said is that we still need the vaccine. We still need the science to come through for us for things like vaccinating our children.
Good point. Thank you for those comments. The children are definitely an important factor in the counts for the population, and we know that some of that testing is still going on. Vaccines are not yet available for the children. I think Dr. Leidiger, that would be an appropriate point to stop with the questions and take any remaining questions, provide responses, and distribute that to the attendees. And if you agree with that, I think it's an appropriate place to end the webinar.
Say goodbye.
Yes, sir. No, that sounds reasonable. Thank everybody for staying on late. The after questions are always kind of nice, but thank you all so very much for doing that, and for the participants who stayed with us as well, and all the good folks, our good friends in Vancouver who helped put this together as well too, Paul and Ernest. So thank you all as well.
Absolutely. Thank you. Any other panelists, if you'd like to offer some closing remarks, you have about 30 seconds apiece we can do here. Start with Manager Valadez.
Okay. Are you able to hear me?
Yes, we can hear you.
Okay. Thank you very much. I appreciate it. I'm going to leave. I have a Central Health Board meeting. But I also want to say that I thank all the efforts that are being provided by Austin Public Health, by Travis County, the CODA effort, Sendero, especially our community care partners in the various clinics that they have, and all the Travis County medical providers that can participate in this program and help us achieve herd immunity as quickly as possible. But I want to stress that we have to have political buy-in. We have to understand that this is not the end game. Success of this program, success of getting out of the pandemic, is not based on how many shots we can get in an arm. It's on how we can structurally change poverty and access to healthcare in Travis County. And that will not change unless we put in place strategies and people and entities that can remain in their neighborhoods and communities post-pandemic and help build them up and provide them the resources that are needed. Thank you very much. Good night.
Thank you, Manager Valdez. Director Hayden Howard, closing remarks.
Thank you for the opportunity to be here. It is always nice to be included when we see data. Data definitely informs our decisions. And thank the other panelists on with us today. I am so convinced that when we all come together, we are able to do so many things together. We identify gaps, we're definitely able to work on those together. So I am definitely committed for us to continue down this path, to do everything that we can do to keep Austin as safe as we can, and to get herd immunity. But I think the other thing that is definitely for certain is that we've got to continue our health equity efforts. As Manager Valadez has shared with us, and she's spot on. This has shown people the things that we know about the disparities in our community. And we have got to continue to come together and think about, post-COVID, how are we going to work together to address the disparities in our community? So thank you again for the opportunity.
Thank you for participating. We really appreciate your thoughts and commentaries and your expertise. Very much appreciate that. Dr. Jennings, any closing remarks that you'd like to share? If you're still on. Okay, I think she actually dropped off already. All right, Dr. Leidiger, that's everybody. I think
that's a wrap. Thank you all.
We're good. Yes, sir. Yeah.
Cheers.
Thanks, everybody.
Take care.